good to me. Thank you, teachers, for all you've done. Now it's time for some summer fun. I'm gonna miss you, my friends. So until I see you again, stand proud, walk tall, get right back up if you fall.
I'm feeling really ready for a little summer fun. Feeling really ready for a little summer sun. Feeling really ready for the year to be done. Have a great summer, everyone.
School's out, we're free. Right now that sounds good to me.
As summer term concludes and we look forward to soon receiving our bachelor's degree, the question we chose for our research question is, do hospitals with a higher proportion of RNs with bachelorette degrees have better patient outcomes? The nursing profession has suffered due to the varied levels of entry into practice and the lack of distinction among levels of education among nurses. With continual changes in healthcare, nurses must remain dedicated to lifelong learning in order to ensure an optimal patient outcome. For this purpose, our study objective is to explore the variables of bachelorette educated nurses and associate educated nurses to determine if there is a difference in standards of care and patient outcomes. Transformation of healthcare requires research and scientific inquiry are driving forces that inform and support the profession of nursing and are generally only included in bachelorette education for nurses. Healthcare environment is constantly changing and new knowledge is created daily. Nursing is a profession that prides itself in being a lifelong learning profession, and it's worthy of educational trajectory to match that standard. Matched with the demands of meeting Medicare and other insurance companies' reimbursements criteria, make higher levels of education necessary. Patients are living longer and suffering from increased chronic conditions. The increase in acuity and diversity in patient populations, matched with the demands of meeting Medicare and other insurance companies' reimbursement criteria, a literature search demonstrates the move towards advanced bachelorette education. The American Nurses Association supports advanced bachelorette education, recognizing the need for advanced preparation provided by the bachelorette education. American Association of Colleges of Nursing reinforces the movement of higher levels of nursing education through support of Carnegie Foundation for the Advancement of Teaching, which acknowledges nursing education as an imperative social issue. Additionally, bachelorette nursing education is highly valued by organizations such as the U.S. Navy, Army, Air Force, and the Veterans Administration. U.S. military requires a BSN degree for advancement or promotion. Furthermore, many hospitals, including Peace Health at Riverbend and Springfield, acknowledge the importance of more highly developed skills of the bachelorette nurse: critical thinking, leadership, professionalism. These skills are essential to patient satisfaction and overall outcomes. Many facilities are pushing for magnet status, a prestigious award given by the American Nurses Credential Center, recognizing healthcare organizations for quality patient care, nursing excellence, and innovations in professional nursing practice. To assist in determining if hospitals with a higher proportion of RNs with bachelorette degrees have better patient outcomes, we turn to a cross-sectional analysis done by Aiken and colleagues. These researchers suggest that nurses constitute the surveillance system for early detection of complications and problems in care. Their study is introduced to determine if educational level of registered nurses is related to patient outcomes. Aiken and colleagues conduct a Level 2 cross-sectional analysis of outcomes over a well-defined study population. They use appropriate recruitment techniques, ensure randomization, eliminate biases and validity threats, and additionally, the Institutional Review Board of the University of Pennsylvania approved the study protocol. The results of the study imply hospitals' employment of nurses with BSN and higher degrees are associated with improved patient outcomes. Additionally, evidence proved surgical patients cared for in hospitals with higher proportions of direct care RNs holding bachelor's degree experienced a substantial survival advantage over those treated in hospitals in which fewer staff nurses had BSN or higher degrees. The sample for this study included 80% of Pennsylvania adult care general hospitals. Data on structural characteristics were derived from 2 external administrative databases. Exclusion of hospitals with missing data. The study excluded hospitals with missing data. The study was an average of 60 nurses per hospital and 52% response rate. The sample was verified to be directly proportional to the number of RN positions in each hospital. The sample verified to meet demographic characteristics. The sample was verified to have met demographic characteristics of respondents of Pennsylvania hospital nurses in National Sample Survey of Registered Nurses. Measures taken. The RN level of education was included: hospital school diploma, associate degree, bachelor's degree, master's degree, or another degree. The mean number of years of experience working as an RN. 3 hospital characteristics used as a control variable: size, teaching, status, technology. Patient outcomes and complications derived from discharge abstracts determined with International Classification of Disease, or ICD-9 codes. Construction of patient risk adjustment model verified by use in previous study. Introduction of 2 variables used to control for surgeon qualifications. With regard to analysis, descriptive statistics and significance tests were computed and compared. Logistic regression models were used to eliminate erroneous data. Patient outcomes were computed before and after controlling for patient characteristics, demographics, and hospital characteristics. Robust procedures were used to adjust for standard error of estimated parameters, and all analysis conducted using the STATA version 7.0 and were found to have a statistical significance of a p-value less than 0.05. A second Level 2 cross-sectional study used to determine if hospitals with a higher proportion of RNs with bachelorette degrees have better patient outcomes was a 2013 Bludgeon and colleague study. Bludgeon and colleague lay the groundwork for analyzing the association between RN education and patient outcomes, controlling for both nurse staffing and hospital characteristics. The introduction of this study supports the Institute of Medicine's 2011 campaign to implement recommendations to support the future of nursing by increasing the proportion of RNs with a bachelorette degree to 80% by the year 2020. Researchers acknowledge obstacles to the Institute of Medicine's goal, indicating the need for resources to provide access to a BS in education, as well as buy-in from health systems and policy leaders through evidence sufficient to support the investment of continued education. The report was well written and organized, provided good detail with regard to researchers' decisions and rationale. Bludgeon and colleagues used effective research design and made great efforts to eliminate serious validity threats. In terms of statistical validity, the fact that the researchers accounted for the potential for type 2 errors but remained under the statistical p-value of 0.05 indicates the findings are of great significance and therefore worthy of transferability. With regard to sample, Bludgeon and Associates used University Health Systems data sets containing diagnosis and procedure codes, actual versus expected length of stay for a period of 1 year. Nurse education information was obtained from the Chief Nursing Officer's database. The sample included 21 University Health Systems member teaching hospitals. Additionally, the study was approved by the University of California, San Francisco Institutional Review Board. With regard to measures, adverse event rates were calculated using patient safety indicator and inpatient quality indicators, and the software used was developed by the Agency for Healthcare Research and Quality. Outcome indicators were adjusted for patient risk using AHRQ procedures to create ratio of observed rates of adverse events to expected rates. Calculation was based upon 30 patients meeting inclusion criteria. Fewer cases were deemed unreliable. Patient outcome indicators based on 2 criteria: indicators sensitive to a nursing care in past research or recommended by the National Quality Forum, and the indicators appeared stable in data set. Patient outcomes: mortality for CHF, hospital-acquired pressure ulcers, failure to rescue, which is death in surgical patients who developed complications, hospital-caused medical infections, postoperative deep vein thrombosis, and pulmonary embolisms. Hospital characteristics were carefully considered. Measures were taken to ensure meeting Medicare's case mix index, which is a combination of low-income, uninsured, and vulnerable populations. Nurse staffing data was aggregated to link with RN education, with separation between staffing levels of specialty areas such as the ICU. STATA version 9 and robust regression with clustering by hospital was used. With regard to analysis, as RN education increased, patient adverse events and length of stay decreased. In areas of congestive heart failure mortality, decubitus ulcers, failure to rescue, and postoperative deep vein thrombosis and pulmonary embolism, as well as shorter length of stay. One noteworthy point to the Bludgeon and colleagues study was that education of RNs did not affect hospital-acquired infections once all the other characteristics were controlled, but nurse staffing levels did. The evidence gives support to further research aimed at understanding the association between nurse-to-patient ratios, patient acuity, and the importance of appropriate staffing levels. The final study reviewed to support our claim that hospitals with a higher proportion of RNs with baccalaureate degrees have better patient outcomes is a 1998 Johnson study. This study is a level 1 meta-analysis covering over 40 years of research directed towards studying association between nursing education and quality of care, with a multitude of significantly relevant studies linking the percentage of RNs in hospitals with BSN degrees to decreased patient mortality. The findings of 139 studies of nurses educated in one of the 3 basic nursing education programs, associate degree, diploma, and baccalaureate degree, were synthesized using meta-analysis. The results indicated a significant difference between professional, or BSN educated, and technical, associate and diploma educated nurses on measures of nurse performance. Specifically, these measures were communication skills, knowledge, problem solving, and professional role. The results of this meta-analysis have implications for policy development about educational preparation and for service expectations of professional and technical nurses. With the evidence reviewed, classified, and critiqued, we set out to test our hypothesis. Hospitalized patients treated by baccalaureate-educated nurses are more likely to experience optimal outcomes and report higher levels of patient satisfaction.
School's out, we're free. Right now that sounds good to me. Thank you, teachers, for all you've done. Now it's
For our project, we have chosen a cross-sectional comparative study design. This type of design is observational and descriptive by nature. It is a design that's commonly used in public health planning. The cross-sectional research is used to examine one variable across different groups. Although the study populations are different, they are composed of members that have similar characteristics. This type of research is based on observation, and it occurs in each of these groups at one point in time. For us in our study, the commonality among the patient population will be the hospitalization in an acute care facility. This type of study, the cross-sectional study, is generally focused on information gathering. This information or data is gathered and then analyzed, looking for relationships between the independent variable and the dependent variables. Once gathered, the information from the cross-sectional study is often used to develop other research projects with different methods to further investigate what looks to be a relationship between variables. An advantage of cross-sectional studies is that they can be done very quickly, unlike the longitudinal studies. Therefore, researchers will commonly start with a cross-sectional study and first establish that there are links or associations that they'd like to explore between variables. They then would set up a longitudinal study to look more closely for cause and effect. Because the study is observational, no experimental procedure is implemented, no variables are manipulated by the researcher. Instead of performing an experiment, the researcher is simply observing and recording information from each of the groups. In the public health world, cross-sectional studies are often carried out to investigate associations between risk factors and outcomes. They are also used to look at prevalence of acute or chronic conditions, or to answer questions about the causes of a disease or the results of an intervention. This cross-sectional study design works well for exploring the question that we have presented, as it allows the researcher to examine several dependent variables, looking for an association with an independent variable. In our study, we would not be looking at a disease or a health condition. Instead, we will be collecting data that reveals the prevalence of positive patient satisfaction levels and outcomes. These are the dependent variables, and then associating them with a higher proportion of the nurses being prepared at the bachelor's level. This is the independent variable. we will look at each of the hospitals where the nurses are employed. Once the study hospitals are identified, a survey tool will be used to query the nurses employed regarding the highest level of education that each has attained. A statistically valid representative sample would be needed from each of the institutions. Patient satisfaction and outcome information will be gathered from reporting agencies and other governing agencies. There is a website on the screen that is an example of one of these. Cross-sectional studies involve data collection at a defined point in time. They also sometimes rely on data that's collected for another purpose. In our study, the outcome information is data that the hospitals submit to the assessment agencies and to Medicare. Because this data is often linked to reimbursement, it will be necessary for us to acknowledge and to control for possible bias in the reported information. Advantages to mining the data that's been collected for another purpose is the ability to access large amounts of information at little or no expense. One of the disadvantages of this is that the routine collected data may or may not be specific enough to answer the question of the researcher. There also may be confounding factors and other unexpected variables may influence the data, even render the data less than useful to the researcher that's involved in this cross-sectional study. Another weakness to the method of collecting data from data that's been collected by someone else is that cross-sectional studies do need to contain individual level information. For our study, an example of this would be the correlation of the individual data, such as patient satisfaction levels, with the level of education for the RN. This could not be projected or become part of the group data, even if patient or the individual belongs to that same group. To compile the data from individual into a group form involves a specific set of statistical tools and some manipulation that is designed to maintain and to assess at the same time the validity. This statistical manipulation is designed to reduce the opportunity of the researcher to assign correlation or association where there is none. The statistical tools for this study are descriptive. These include the mean values, the standard deviations, and percentages, as well as significance testing. This will allow the comparison of the hospitals and between patient groups. In a cross-sectional study, information or data is often gathered in a survey format. This will allow the data to be gathered and collected on individual characteristics alongside the collection of data about the outcomes. This will allow us to gather information to create a risk adjustment when looking at patient outcome. In our study, another example of this would be collecting information about the individual hospital characteristics at the same time that we are collecting their outcome data. According to the text, cross-sectional studies also use odds ratios. This is a term that describes a statistical measurement. It's used to speak to the strength of association between two data variables. In other words, how likely is this association to be a valid one? The term prevalence describes a portion of a population that has a particular condition. The prevalence risk ratio is a statistical tool that will describe a feature of a population and will also at the same time can be used to support inferences of cause and effect. And these are often used in cross-sectional studies too. An example of this for our study would be statistically examining the data compiled and then projecting the feature of improved outcomes associated with a purposeful increase in the baccalaureate prepared nurses at the bedside. Once the statistical work is done, cross-sectional studies do allow the researcher to discover associations. In our study, it is expected that an association will be discovered between the proportion of baccalaureate prepared staff and positive patient outcomes. As previously stated, cross-sectional study design does not have an experimental intervention. Instead, a cross-sectional study design looks at an independent variable and seeks to find if there is a correlation or a relationship or an association between dependent variables in a population group. Again, the independent variable in our study is the baccalaureate prepared nurse at the bedside. First, it is important to define our terms. The associate degree nurse is generally educated at the community college level. The time frame for the education averages about 21 months. The programs are focused on technical nursing skills and bedside expertise. Once graduated, the nurses are qualified and authorized to take the NCLEX exam, which is the credentialing exam for a registered nurse. On the other hand, a bachelor's degree in nursing is an educational journey that lasts about 4 years. It too is focused on technical nursing skills and bedside care. The additional 2 years add a level of understanding and learning that is focused on developing expertise in leadership, critical thinking skills, understanding and participating in research, management skills, management of a team, management of a clinical group, or management of a patient group. In a BSN program, a deeper look is actually taken at some of the more specialized population groups that are very likely to present themselves at the clinic doors. As we looked at this cross-sectional study design, we did identify some possible limitations for the proposed study. One is the possibility of a small sample size. A second one is the limit in the time the study is in place, limiting the duration and the scope and possibly the information. To acknowledge the risk of a type 2 error and to allow for that possibility of a smaller size sample, which is being used with a large number of predictors, we decided to report findings that had a p-value of less than 0.01. Another limitation of the study, which looked only at acute care hospitals, is the inability to generalize to other populations, such as extended care, outpatient facilities, or community health clinics. Caution would also be needed in applying the findings to hospitals with a wide variety of acuity levels, such as rural community hospitals. As previously noted, there is a possibility of a limitation associated with response bias.
Outcome component. One of the first expected outcome components that we will see will be staff with increased clinical expertise. This outcome component is of great importance because staff with an increased clinical expertise are better qualified to handle patients, manage patient care decisions, improve diagnosis proficiency among BSN nurses. Nurses trained with BSN education have higher level competencies than ADN nurses. BSN nurses are promoting an industry standard and current trend among nurses. Staff with increased clinical expertise are also able to better manage patient satisfaction and patient safety. Improved patient satisfaction automatically takes place when you have staff with increased clinical expertise. BSN trained nurses that provide excellent clinical care maintain patient satisfaction through clear communication, education, and by providing patients with a continuity of care. Patient safety is also increased as part of patient satisfaction because BSN nurses have the ability to provide greater critical thinking skills, problem-solving skills, and promote healthy choices and lifestyles. As previous studies have reported, there is a decrease of mortality and morbidity, rehospitalization, infection rates, medication errors, and adverse sentinel events when BSN nurses are employed and providing care. So to reiterate the outcome components, staff with increased clinical expertise automatically contribute to an improvement in patient satisfaction and patient safety. The better and more capable you are able to do your job, the happier your patients will be. Increased clinical knowledge and ability to critically think leads to a proficiency in clinical decisions and professional integration of one's nursing knowledge. All of these skills help a BSN nurse to better take care of a patient. Application to practice. So how does this all apply to practice as a BSN nurse? Bachelorette degree education allows us to advocate for better employer incentives. What we mean by employer incentives would be tuition reimbursement programs that allow a nurse to pursue a bachelor's degree nursing education, wage incentives to make up for the increased cost and expense that it takes a nurse to pursue a BSN education. And an example of a wage incentive would actually be a recent situation where the ONA negotiated for increased pay among bachelor's educated nurses in a newly ratified contract that actually just recently was enacted in a local hospital. There was also expansion of practice along a continuum of care. And what we mean by this is the bachelor's educated nurses are equipped with the skills to follow a patient across the lifespan in providing health care and symptom management. Bachelor's educated nurses are very diverse in their knowledge of nursing, ranging from management to bedside care to financial and insurance practices, along with other safety practices, so that they are better able to fill in gaps and provide nursing expertise in a multitude of areas as opposed to clinically trained ADN nurses. Bachelor's nurses are educated in leadership, maintain better communication, as well as higher competencies, as we previously mentioned, and provide for increased patient outcomes, safety, and satisfaction. All of this provides many financial benefits to the healthcare organization. By decreasing errors, sentinel events, and other patient safety compromises, we are improving the financial standing of an institution. We are also promoting industry standards and helping hospitals to achieve higher proportions of BSN nurses that are necessary for accreditation among many organizations. And anytime we're providing quality patient care, we're promoting the values and basis of nursing practice. With patient-centered care being the primary focus of nursing, an improvement of quality is at the basis of nursing and is a reflection of nursing standards. In conclusion, this study aims to identify the importance of a BSN education on nursing practice and the implications to patient care. The American Association of Colleges of Nursing states that the federal government, the military, nurse executives, healthcare foundations, nursing organizations, and practice settings acknowledge the unique value of baccalaureate-prepared nurses and advocate for an increase in the number of BSN nurses across clinical settings.